Good afternoon, good evening, and welcome to this BTOG Masterclass, the latest in our series of approximately monthly webinars. And we've called this one Peri-Operative Therapies. And I'm expecting, I can't actually see the numbers yet, but I'm expecting there to be quite a lot of people online for this one because we've got two very topical subjects and two really first-class speakers who I will introduce you to in a moment. The usual kind of webinar housekeeping. I think we can go on to the next slide, having shown you lovely pictures of Dawn and Gina, who without whom none of this would be happening. You can submit your questions. Really importantly, it is very easy to submit questions, and this is what really makes a difference. I think the accessibility of our speakers in these webinars. So do please feel free to submit a written question through the text control panel at any time, and I will collate those and recycle them to our speakers. We're going to have a Q&A after each of our presentations today. Afterwards, you can send us your email feedback, and if you do that, we can, in response, send you a certificate of attendance if you need that for CPD purposes. So this is our agenda. We will get you out of here in time to see a little bit of the evening sun, I hope, within the hour. The speakers who we've asked to divide between them the two subjects of targeted therapies in the adjuvant setting and immunotherapy around the peri-operative situation are Alastair Greystoke and Samreen Ahmed, who, between them are, I think, without doubt, two of the leading lung cancer opinions in the UK and really globally. So we're very privileged to have their time and to have the opportunity to ask them questions afterwards. So without any further ado, Alastair Greystoke, you will be familiar with, I'm sure. He's senior lecturer and consultant medical oncologist at Newcastle University in the Northern Centre for Cancer Care. And his subject is adjuvant targeted therapy. So over to you, Alastair.
Thank you very much, and thank you very much to BTOG for inviting me to talk about this really interesting area. As always, where you present these and develop these slide decks, you end up learning as much as when you talk about it to an audience, and really looking forward to your questions. These are my disclosures. I'm going to actually start off today with a clinical case that all of us might encounter in our MDTs. So this is a 52-year-old man. As you can see, he's a never smoker, completely fit and well, past medical history of hypertension on losartan, and the increasing cough on losartan led to him being investigated. And so he's been worked up appropriately by the respiratory physicians with CT, PET, CT head, and a biopsy, and been brought to the MDT, and staging is T3 and N1 M0. And certainly at this time, normally when I'm sitting in the MDT, I'd go to sleep and check my email because this patient is not for me. He's got surgically resectable disease, and the surgeon needs to be at them. But then it turns out on the biopsy that not only is this an adenocarcinoma, but with his non-smoking status, he has one of the common mutations in EGFR. The other oncogenes are negative, and we've also done the PD-L1 status, which is 55%. And so you have to wake up because the MDT have asked you some questions. Number one, they want to know is, well, what's the implications on prognosis of this EGFR mutation? Is this patient going to do better or worse? And what should we be doing in terms of treatment? Are you going to recommend some drugs either before or after? Are you going to recommend an EGFR TKI, some chemotherapy, or even some immunotherapy, given that high PD-L1 expression? So I'm hopeful that by the end of this evening that you will be able to answer all those questions appropriately. I'm going to concentrate on EGFRs because, as with all targeted treatments, this is the one where our treatment paradigms have changed, but we will start to talk about some of the other key molecular abnormalities as I come to the end of my presentation. So what about prognosis first? So this is a publication of the ETOP Landscape platform. So looking at surgically resected tumors in Europe, you can see that their EGFR rate was, I think in the adenocarcinomas was about 15%, which is slightly more than I see in the Northeast, but about right for Europe. And what you'll see if you look at the Kaplan-Meier on the right is that they commented that there didn't seem to be any particular difference in survival in the EGFR mutant patients in the blue compared to the rest of the population in the red, suggesting no prognostic implications. There is also this complicated meta-analysis out there that was published a few years ago, again, looking at the implications of EGFR on survival in a resected setting. And what you can see on the left is the forest plot after they removed some of the more heterogeneous studies. And you can see they came up with a hazard ratio of 0.77, suggesting that these patients might do slightly better than the patients that are not EGFR mutated. And if you look on the overall survival on the right, this seemed to be feeding through to overall survival. However, that you can see that many of those studies are very small and were quite heterogeneous with large estimates about survival. So I think this does need to be taken with a slight pinch of salt. So in terms of prognosis, I think you have to be saying to your MDT, well, it may be slightly better, but maybe not, a bit unclear. So I guess the real driver for this presentation is that we now have access to osimertinib in the adjuvant setting. So following on the publication of ADAURA in the New England Journal of Medicine. And then in the new Brexit world, we have different regulatory hurdles. And the first one that came through what's called Project Orbis, which is a joint way of evaluating drugs between America, Canada, Switzerland, and the UK, was osimertinib, and the funding was agreed with AstraZeneca at the same time. So pretty much straight away, we are now able to give adjuvant osimertinib. So let's look at some of the data and underlying that. So this is the slide outlining the ADAURA study design that was presented at ESMO initially. And there's a few things I wanted to point out to you in terms of how we interpret this data. So number one, this study was only for EGFR with common mutations. There was one patient that also had a T790M mutation concomitantly, but none of your rare exon 18 or exon 20 mutations would have been eligible. They had to have a resection for T1B to 3A disease, and that was staged using TNM7. There are some slight differences between 7 and 8 that we can talk about if required. And they had to be randomized within 10 weeks of adjuvant, if they didn't have surgery, if they didn't have adjuvant chemotherapy, or 26 weeks if they did. And that's now fed forward into the blue tech form we have to fill in. They had treatment for up to 3 years if they didn't develop recurrence. And you can see that they got imaged relatively frequently. So week 12, 24, every 24 weeks up to 5 years, and then yearly thereafter, but with no mandated brain scanning, which is important when we look at one of the endpoints that has been reported. So you'll be aware that this was a positive study. Actually, the primary endpoint was restricted to the stage 2 to 3As. The 1Bs were not included in the primary endpoint, but you can see a very positive study, a major impact on disease-free survival with a hazard ratio of 0.17, median disease-free survival of 19.6 months and not reached in the osimertinib arm. Still relatively immature, you can see lots of censoring occurring around about the 36-month mark when patients will be starting to finish their osimertinib, or sometimes even before then. They did also present the data for the whole study population, including stage 1B disease, and you can see that, again, this was still positive, hazard ratio 0.2. And we have our beautiful forest plot showing that the benefit of osimertinib in terms of disease recurrence was seen across all key subgroups, including, I'll demonstrate some important ones, so no difference between Asians and non-Asians. The stage 1Bs maybe not getting as much benefit as the 2 to 3As, which are at higher risk of relapse. Both mutation types seem to be relatively similar, maybe more benefit in the exon 19 DELs, and that was also seen in FLORA. And also, and importantly for our clinical practice, no difference if you received adjuvant chemotherapy or not. And in the primary population of stage 2 to 3A, 76% of them did receive adjuvant chemotherapy. It's much less in the stage 1B as you might anticipate. But most of these patients did receive adjuvant chemotherapy. So questions when we're thinking about how we take this forward. So we've got disease-free survival. Does this correlate to overall survival? if patients do relapse, where are they going to relapse? And then what do we do with them when they relapse? And is there any differences in how we can manage them if they relapse when they're on their 3 years of treatment, or 1 or 2 years later? And if we are going to use osimertinib, which we regard as a well-tolerated drug in the metastatic setting, is it different when we give it in the adjuvant setting, where patients may not experience some of the improvements in disease-related symptoms that we'd expect in the stage 4 setting? So a couple of studies I just wanted to comment on if we're talking about overall survival. So this was the adjuvant study run in China, the Xitong study, where they looked at patients with resected EGFR disease, and they randomized to either chemotherapy or gefitinib. And they presented a couple of years back in ASCO and showed a positive hazard ratio for disease-free survival at 0.56. So not as good as we saw in the osimertinib ADAURA study, but what you'll see is they recently updated for overall survival, and there was no difference in overall survival seen. So in this context, disease-free survival did not, but this was gefitinib versus chemotherapy, and a smaller study. This is the RADIANT study, where they gave adjuvant erlotinib, regardless of whether you had an EGFR mutation or not, but they did do a key subgroup analysis of the EGFR mutants. And again, they reported a positive disease-free survival benefit in the EGFR mutants in those patients that received erlotinib in the JCO publication. And Professor O'Brien kindly gave me the presentation from ASCO in 2015 later that year that showed no survival benefit again. But again, if you look back at the hazard ratio for disease-free survival, that was 0.61. So not what we're seeing in ADAURA, but once again, a study showing disease-free benefit, but not necessarily translating to overall survival benefit. And this is the very early survival data coming out of ADAURA, where there's only been 29 deaths, 20 in the placebo arm and 9 in the treatment arm, so far too early to call at present time. And just lastly, to show this is again is a key meta-analysis which includes ADAURA and the disease-free survival, showing that there is the major benefit of using these EGFR inhibitors in resected EGFR cancer, but that if you take out ADAURA and look at the previous studies, even on meta-analysis, it doesn't quite reach significance. So what about recurrence? Where do these patients recur? And particularly when we looked at the RADIANT study, there was a suggestion that there may be relatively high recurrence in the brain. And we know that in the stage 4 setting, brain is a major problem. So if you look at the graph on the left, you can see relatively small numbers of patients relapsing in the brain, less than 1%. And this was presented in the New England Journal paper as CNS disease-free survival, and again was very positively significant, with, as you can see, very few events in the osimertinib arm. But interestingly, you do see that a couple of events that did occur were happening around about that 3-year mark when patients were discontinuing their osimertinib. So tolerability, I said it was key. So I've presented this a couple of different ways. So obviously within the study, you've got the osimertinib and placebo arms, and that gives you an idea of the extra impact of giving the drug. But you've also got the FLORA study of using it in the stage 4 setting. And so what you can see is that the level of grade 3 events and SAEs were slightly higher in patients receiving osimertinib, about 4 or 5% higher, but nothing compared to what we see in the stage 4 setting, where patients will run into more problems with their cancer. You can see the level of dose reductions was slightly higher in ADAURA than it was in FLORA, but actually the discontinuations due to toxicity were actually slightly higher, interestingly, in FLORA than they were in ADAURA, suggesting that this was indeed tolerable in this population. Of note, when we're talking to patients, there was a 3% ILD rate, interstitial lung disease rate, which we know, and that was relatively similar to what was seen in FLORA. So we do need to consent patients appropriately for that risk. So we've got data in the adjuvant setting, and so there's always, and we know that in the stage 4 setting, you see a very high response rate. Well, what about bringing it into the neoadjuvant setting? So this is the early report from ASCO of a study that's ongoing in the setting of 28 patients. And what you'll see is a high response rate, as you'd expect, 71%. All patients, apart from one having an R0 resection, relatively high degree of pathological downstaging, including in some of the patients that had N2 disease, and one patient who had a pathological complete response. So very provocative early data. There is a proper study unrolling at the moment called NeoADAURA, which is going to randomize 328 patients to either osimertinib alone, osimertinib with chemotherapy or chemotherapy alone, with the major outcome being, the primary outcome being major pathological response. And I'm sure we'll hear a little bit more about that endpoint during Samreen's talk. But that'll be a very interesting study to see that may help us guide these patients' care in the future. And I did say I'll talk about other molecular subtypes because it's just not about EGFR anymore. We've got a number of treatments that are already well established in our NHS practice targeting ALK and BOS1, and over the last year or so, got access to BRAF and then TRAC inhibitors, with a number coming through this year, including an EAMS that's just opened for MET inhibitors and potential access to a big population that have KRAS G12C mutations that I'll touch on right at the end. So theoretically, there's a large number of patients we could consider for this targeted approach in either the neoadjuvant or adjuvant setting. So 2 studies just to touch on in the ALK setting. So a large phase 3 study, ALINA, which is looking in patients who have resected ALK lung cancer, but slightly disappointing to me, this is set up more like the adjuvant EGFR study. So patients either have alectinib or chemotherapy. It's not an after chemotherapy study, and that always leads people can always lead to some criticism about, you know, how patients would have done if they had chemotherapy and then the ALK inhibitor. And it's 2 years of treatment rather than 3 years of treatment as in ADAURA. You can see the primary outcome is disease-free survival again. And there is also a neoadjuvant study for those patients that have slightly higher bulk disease. This is a very small phase 2 study where patients get a lead-in of 8 weeks of alectinib, then go on to surgery and then have adjuvant alectinib for 2 years. Going back to that sort of primary outcome measure of major pathological response that we'll see in a number of the neoadjuvant studies. And, you know, so a number of the populations that we looked at before are relatively small, you know, including things like RET and BRAF, including ALK. So can we actually afford to run separate studies in these patients, particularly in the neoadjuvant and adjuvant space where traditionally studies have been quite difficult to run? So I think the Americans are leading the way in this through their Lung Cancer Mutation Consortium. They're trying to set up a widespread screening of all patients going forward for resections, and where they can then, in almost like a matrix study approach, then put them on neoadjuvant treatment for 2 months with extensive biological correlates to really look in relatively small numbers as to which of these strategies should be promising and can be taken forward. And you can see some of the arms that are planned within that study already. And lastly, I did just want to touch on KRAS G12C because a number of us may be starting to treat this a relatively common mutation, which is about 10% of our population. In fact, it's even more in my constituency. In the Northeast, we have almost 15% of our patients have KRAS G12C. Going back to that meta-analysis that I showed about survival in resected EGFR, they also commented on survival in resected KRAS cancers. They didn't break it down by particular mutation type, but you can see that overall they said that these patients did significantly worse than KRAS wild type patients in the resected setting. Sotatercept has just been licensed in America. It is not yet licensed in the UK. But I've shown the waterfall plot from the New England Journal showing a response rate of 40%, but also showing that there is a relatively short median progression-free survival of approximately 6 months. And we're already starting to see papers coming out about resistance mechanisms and how cancers can become relatively rapidly resistant to this agent. So it sort of leads to the question in my mind as to whether this drug in particular might be one that we might want to use in the neoadjuvant setting rather than the adjuvant setting. So I hope I've summarized very quickly within the purposes of time, and be delighted to take some questions to go into things in more detail. But to highlight for you that, you know, adjuvant osimertinib is now available for our patients that have a resected EGFR mutant lung cancer, bearing in mind the strictures of the BlueTech form, which are that patients need to be fit, have an R0 resection and the common mutation. There are important issues surrounding that study that you need to think about when discussing it with colleagues and with patients, that there is no overall survival data as yet, that this is not a substitute for chemotherapy. Most of those patients did have adjuvant chemotherapy within the study. And treatment on relapse, it remains unclear. I get more concerned about those patients who finish the 3 years of treatment and then relapse, because I think it's unlikely in the NHS England setting that we will then be able to give them osimertinib again, which is our most potent weapon in the stage 4 setting. So that will be something to think about in years to come. I think coming forward in terms of future work, it's clear that we're going to be kept very busy looking in the precision space at neoadjuvant or perioperative strategies of, that potentially giving 8 weeks of upfront treatment and maybe 2 or 3 years of adjuvant treatment in patients that have had response. And that's going to come across a range of molecular subgroups. Some of them, like the KRAS G12C, should be big enough to do proper studies on. Some of them, like RET and certainly the NTRKs, may be so rare that we'll never be able to do proper studies except as small cohorts within a platform study. And lastly, just remember that testing is key. This, to my mind, gets rid of the nonsense that we should only be EGFR testing in the stage 3 or 4 setting. It is very important that all patients with lung cancer get their tumor fully profiled at presentation, so we can guide MDT discussions, discuss prognosis and potential treatment options. And with that, thank you for your attention. I'm delighted to take questions.
Fantastic. Many thanks, Alice. So what an excellent overview. So building on one of the stimuli for this webinar, which was this really important ADURA study, which is changing practice around us. And as you highlighted, we now live in a world where presentations at international meetings and high impact publications aren't just for the academics. They really change practice within months, which is after people like you and me practicing for many years in the NHS, where we felt like sometimes in a parallel universe, it's a much more comfortable place to be. But we do end up with some of the really interesting questions that you posed, like what do we do with this early data where we have dramatic PFS benefit but no definitive OS data just yet. Well, maybe we could start with that as a first question then. So what informs your conversations with patients in this context, where they come to you post-surgery, they've got an activating mutation, and it's the sort of patient who really wants to hear the issues. I understand this might stop the cancer coming back, doctor, but if it's not going to make me live any longer, do I really want all those side effects? How do we help patients make that decision? And perhaps the very next question they might have for us is, wouldn't it be better to save this drug for when if the disease does come back?
Yeah, no, I think those are very good questions. So the sort of things I'm discussing at the moment is that if you are a believer in hazard ratios, and I have to say I'm not a great one, but the data for ADURA was stronger than for the adjuvant and the radiant studies. So that's one thing I would point out. The second thing I would point out is that 3 years of living without active cancer, particularly EGFR cancer, you would hope would translate into quality of life benefits, although we have not seen that properly as yet. And in general, osimertinib is, a very well tolerated agent. Going against that, the 3% ILD rate is not zero. I think we do see more ILD with osimertinib than we do with the other EGFR inhibitors, and that seems to have translated across to this study. And this issue about, what we do on relapse. Having said that, so saving your best drug for when you have stage 4 disease, I don't think that's the right thing necessarily to do. Because of the impact of the cancer, these often young people will often end up with CNS or bony disease that can be quite debilitating. But I'm sure a lot of us are now using osimertinib in the first line setting. And when you use osimertinib in the first line setting and then it becomes resistant, and we're all aware that some patients do become resistant relatively quickly, we're then really stymied and we're starting to run out of options. So I don't think I would advocate just waiting until the patient has stage 4 disease. So at the moment, I would be very upfront with them and say we don't have survival benefit, but I would probably be suggesting that this is something we should think about. I think it will be really interesting to see some of the biomarker data coming forward, to see if things like cfDNA can help stratify patients who should have this. And equally, we know there are other oncogenes that lead to poorer prognosis in patients with EGFR, particularly P53. So whether in particular, in the future we'll be saying, oh yeah, you've got a classic EGFR exon 19, you're fine, you can maybe not have adjuvant osimertinib, or actually you've got a P53, you're at high risk, you've got a nasty cancer, maybe we should. But we don't have that data as yet, but hopefully we will coming forward.
Okay, we've got some questions coming through on the chat now, and just a reminder to the audience, you can ask your questions during the next talk. You don't have to wait for the end, and that'll help me to prioritize them. But just before we come to them, and one or two very clear questions with very emphatic answers, I think that we do need to leave time for. Just coming back to the discussion with the patient. So we don't know this yet because we haven't had any patients come through far enough on this therapy in this setting, but how do you think, fast forwarding, we're going to be treating patients who maybe have had an adjuvant course of osimertinib, then have a progression-free interval and then relapse?
Yeah, I think that's going to be very difficult because we know in other countries they'll be able to re-challenge, and that will be the data that will guide us. Whether we will be allowed in NHS England, I suspect not, and whether we'll be allowed to use some of the cheaper more first or second generation inhibitors, again, I don't know, because the other option is going to be stopped.
Probably what we should be allowed to do, Alastair, is re-challenge in that context, isn't it?
Yeah, well, you're going to, I guess we'll see data coming through from that, but I'm sure that's what's going to happen to patients on the study, isn't it? Most of those weren't treated in the UK environment, and I would have thought, we'll see what subsequent, I'm sure they'll report on subsequent EGFR use, and I suspect a lot of it will be osimertinib, particularly those who progress after the 3 years.
Okay, now first, thanks for that. The first question from the chat is, this is an important thing to clarify. Should patients eligible for this ADAURA type treatment still have adjuvant chemotherapy? And I know you've mentioned that already, but perhaps you'd just like to underline that point.
Yeah, no, I know. The study data was using adjuvant chemotherapy, and you have to be very clear about that. And I hope I was, that this is not a substitute for chemotherapy. This is an add-on in the vast majority of patients. The subgroup analysis did suggest that the benefit was regardless of having chemotherapy or not, but the vast majority of patients who were in that primary outcome with that hazard ratio of 0.17 had adjuvant chemotherapy. So, I would be advising that patients who meet the criteria for adjuvant chemotherapy and are well enough should still be having adjuvant chemotherapy. And then I would be talking about them about moving on to adjuvant osimertinib afterwards.
Thanks. And then the next one is, which EGFR mutant patients are not ADAURA eligible? Now, I think we could probably interpret that question in a few ways, but let's start with a straightforward one. Biological one. What do we do with patients who don't have the common exon 19 deletion or exon 21 point mutation?
Yeah, so you won't be allowed to treat them in the NHS because the Blue Tech criteria is very clear that it's only common mutations that they are suitable for, and that's where the data was generated. And in fact, most of the data for osimertinib in general, even in stage 4 setting, is in common mutations. There's some emerging in rarer mutations, but so yeah, you won't be able to treat them. Yeah.
Okay. And are there any other, while we're on the subject of eligibility, and maybe this is what the question had in mind, are there any other contraindications to OSI in the adjuvant setting? I can't think there's anything very specific.
I don't think so. Patients need to be fit, but you'd presume if they've got through the surgery that they should be relatively fit. There's some contraindications about QT. You should be checking their QT interval and ECG and stuff like that. But I'd be surprised if a patient who had been fit enough for surgery would not be fit enough for adjuvant osimertinib.
Right. Okay. What about testing? You alluded to this in, actually there it is in the screen in front of us, the last point on your summary.
Yep.
Testing. What's our perception across the country? In some respects, this should make things easier, right? We don't have to hold our pathologists' hands when they're hand-wringing about which patients to test. If you've got a lung adenocarcinoma, you need to test it no matter what the stage of the patient has come from.
Yes, and that should actually make our pathologist's life easier. Although I work very closely with pathologists through the GLH, and I think it's fair to say that they're struggling at the moment because of workforce and everything else in terms of COVID. So do be gentle with your pathologist, but if they say, well, we shouldn't be treating in early stage disease, no, you have to say to them, no, I'm sorry, we need to do it. I accept that your workforce this may be a challenge to implement. How can I work with you to implement this? But actually, as you say, it should be easier because they shouldn't need to be going back to the blocks in the long run.
Yeah, so it should be easier, but doesn't mean it will, right? I suppose extrapolating from when EGFR testing first came along, it was alarmingly late in the day that we got to any kind of clear homogeneous rollout of testing with equality of access around the country. Yeah. So a little bit of a learning curve for the multidisciplinary teams of the UK and elsewhere, I expect. Alastair, that's been tremendous, and we could go on discussing, and the questions are still coming in, but we've hit 6 o'clock, and if we're going to give Samreen a fair crack, we better move on. So we're changing tack a little bit now from targeted therapy in the perioperative setting to immunotherapy. And once again, we have some important clinical data recently emerging, which I'm sure will be the nucleus of Samreen's discussion with us. Again, knowing her extensive experience and knowledge of this area, she'll be telling us an awful lot more besides. So Samreen, again, you'll be familiar with. Professor Ahmed is a consultant medical oncologist in Leicester, and her title is Immunotherapy Moving to Operable Disease. And there's no question mark, I note, Samreen.
There's no question mark, that's right. Thanks, James. These are my disclosures. And as this was a masterclass, I've made this over-inclusive, so please forgive me, and I'll be going through this very swiftly. So those of you who are new to thoracic oncology, I want this to be inclusive, and hopefully you get a little bit of background from what I'm talking about. So we all know what immunotherapy or checkpoint inhibitors are. It's this PD-L1 and on the T cells, the PD-1 on the T cells and PD-L1 on the tumor cells, which we're looking at as the interaction of this T cell with the tumor cell, which is inhibitory, and these antibodies block it. So we've got nivolumab and pembrolizumab, as you know, targeting PD-1, and then you have atezo, durva, and avelumab targeting PD-L1. So a great effort by drug development and clinical trialists over the last 5 to 6 years has really transformed how we treat non-small cell lung cancer, and checkpoint inhibitors have been the backbone of treating lung cancer for the last 5 or 6 years. And I'll just go through a few pivotal studies so that you know why we're now moving immunotherapy into operable disease. So this was, to me, landmark study, Keynote 24. And those of you who've not seen this study, this is for stage 4 non-small cell lung cancer, the first time that PD-L1 really was used as a biomarker. And this was specifically using TPS of over 50%, so the really high expressors. And it's randomized 1-to-1 pembrolizumab versus platinum doublet chemotherapy, primary endpoint PFS. And just to point out, on progressive disease, there was crossover as well. So that's really important to remember when we're looking at overall survival. So here we are at 11 months. There was a massive difference, and this was presented which year was it? I can't remember which year now, 2016, ESMO 2016. And there was a standing ovation with this, and people couldn't get into the hall to hear this. I remember there was a crowd outside, and this was really remarkable change for treating advanced non-small cell lung cancer. Then we looked at more mature data on this study, and this was the updated overall survival. And still, out at 18 months, we were seeing a big difference, that we were getting 60% of our patients surviving at that point. And this was a follow-up of 19 months. So no doubt, very positive and significant pivotal study in non-small cell lung cancer in the advanced setting. Then we noted, if I just go back one, when you looked at this PFS curve, you saw this sudden downfall of patients within the first 3 to 6 months. And we really couldn't wonder why this was, and why were patients falling off their perch early on in the disease. And it looked like as if some patients had very progressive disease, and therefore immunotherapy hadn't got enough time to work. And therefore Keynote 189 was a study looking at combination of chemotherapy with checkpoint inhibitor, namely pembrolizumab. And that was the theory behind it, that it was to try and salvage that fall off that we got in that first line setting with single agent checkpoint inhibitors. And this is a very straightforward study looking at stage 4 patients, again, randomizing to platinum doublet with pembrolizumab or just platinum doublet. The primary endpoints were overall survival and progression-free survival. And these were the curves, very, very positive. As you would expect, the higher the PD-L1 expression, the greater the difference you saw between giving checkpoint inhibitors and chemotherapy versus chemotherapy alone. And significantly, this really established the role of combination chemo checkpoint inhibitors in non-small cell lung cancers. A very similar study, 407, was done in the squamous population, and this showed very similar results. The design was exactly the same. So, NICE approvals, as you know, single agent pembrolizumab for really high expressors, and most of us use this single agent pembrolizumab in patients who we think have got smaller volume disease, not that symptomatic, high expression, and we can get away with just single agent checkpoint inhibitors. Most of us now have moved to combination chemotherapy and pembrolizumab in any PD-L1 expressors, and those with high PD-L1 expressors, we're using this for bulky symptomatic disease. So then obviously everything that we use in advanced disease, we then move into the earlier setting. And then this is a pivotal study, which you'll all have heard about, Pacific study looking at inoperable stage 3 disease. Again, this was using concurrent chemoradiotherapy, then moving on to a year of durvalumab versus placebo. And there was no crossover here. The co-primary endpoints were PFS and overall survival. And this was, don't forget, inoperable stage 3 disease. And you've all seen this result, and it's really staggering at 4-year update, overall survival, more than 10% difference using durvalumab. Okay, so I would argue really that we're now reaching a stage where concurrent chemoradiotherapy, though I know it was inoperable disease, is challenging stage 3 disease that we send to our surgical colleagues. Okay, so a few important considerations when we're trying to move from advanced disease setting to a curative position, because what we want to know is, first of all, outcomes of SACT given neoadjuvantly, are they the same as adjuvant? And you've all seen this, so I just wanted to capture this in a table. This is adjuvant chemotherapy trials, and a LACE meta-analysis showed that there was 5% overall survival difference in at 5 years using adjuvant chemotherapy in 4 centimeter large tumors, or stage 2 to 3 disease, and that was well established. And then we had this the systematic meta-analysis looking at pre-operative chemotherapy in non-small cell lung cancers. And these are really difficult studies to recruit to, I have to say, and can be quite heterogeneous. But the 15 of these randomized control studies were used in this meta-analysis. And again, it showed exactly the same survival difference really as you would see in adjuvant setting. So 5% difference at 5 years using neoadjuvant chemotherapy. Now, does that then translate to immune checkpoint blockade? And we just need to wait and see, but we can probably say that adjuvant versus neoadjuvant chemotherapy is exactly the same. So the next question is immune checkpoint inhibitor blockade safe preoperatively? Because the last thing we want to do is compromise patients who are in this curative setting and not allow them to have their curative operation as a consequence of toxicity. So we had a range of phase 2 trials looking at safety, feasibility, achievement of surgery, surgical feasibility rate, some of their endpoints were pathological, a complete pathological response, and this major pathological response, which I'll tell you about in a minute. And that was pretty much established that immune checkpoint inhibitor blockade was safe pre-operatively. It did not confound patients going to have surgery. So we were pretty sure about that. The next consideration really is, does pathological complete response rate have prognostic value in non-small cell? And is that going to translate into disease-free survival or overall survival? And we've seen that in breast cancer, you know, there's a big argument, lots of studies done. So these are some of the studies that have been done with chemotherapy, looking at pathological complete response. The one I've just highlighted is the only one that's been using checkpoint inhibitors. So essentially, we've got quite a lot of evidence suggesting that pathological complete response is probably a good surrogate marker for disease-free survival. I'm not sure that overall survival we can make that leap yet, but hopefully the data is accruing. There is another entity that we've seen in non-small cell lung cancer called major pathological response, and that is when there's less than 10% viable tumor cells detectable in the resection and nodes, and this strongly correlates with survival. So I think we can safely say that complete pathological response and major pathological response can be used as surrogate markers in our clinical trials, because disease-free survival and overall survival obviously takes such a much longer time and are more expensive, both cost-wise and for patient-wise. So we've got, looking at getting to the meat of this talk, neoadjuvant chemotherapy, immunotherapy studies, and we've got 3 ongoing at the moment. And I'm going to tell you a little bit about Checkmate 816, which is recently presented. So this was a study looking at large tumors over 4 centimeters, and all of those patients really that you would be considering for adjuvant chemotherapy. So stage 1B to 3A disease. They had to have good ECOG status. They were stratified by stage and PD-L1 expression. And they received 3 cycles. So 3 cycles of chemo-nivo, so platinum doublet and nivolumab, only 3 cycles versus chemotherapy alone. And they then received surgery. And the main primary analysis was presented for the above 2 therapies that you can see. And the primary endpoints there were pathological complete response, and secondary endpoint was major pathological response and overall survival, which we haven't got yet. So really just looking at a summary of treatment and surgery summary. This was again presented recently. So majority of patients were able to complete 3 cycles of chemotherapy and chemotherapy nivolumab. And this is stage by stage I suppose categorization of the patients, and you can have a look at this in detail actually, but just for brevity of time really, the main take-home messages here are when we gave patients nivolumab and chemotherapy, it seemed that they appeared to have obviously a greater response rate, but also the time that it took during the surgery was much shorter. Their complication rate seemed to be much less as well. And the next slide, I think, has got, here we are. Yes, so this has got the complication rate. And really what struck me was the level of pain that patients on chemotherapy experienced with the surgery. And I think that probably suggests that they were able to have, those patients who had nivolumab and chemotherapy were able to have less maybe VATS thoracotomy rather than open thoracotomy, and therefore they were experiencing less pain. And certainly the tumors were much smaller when they got in. So I'll show you that in just a minute. And in terms of adverse events, really there wasn't very much a discontinuation compared to chemotherapy. So immunotherapy didn't lead to too much adverse events as we were hoping that was the case. And then looking at the primary endpoint, a significant difference in overall response and in complete pathological response, and then in major pathological response. There's a very big difference compared to chemotherapy. And this was the primary and the secondary endpoints of this study. And then if you look at the waterfall plots, so these are individual patient data, you can see a greater proportion of patients in the Nivo chemo arm achieving both pathological complete responses and also major pathological response compared to chemotherapy alone. Okay, so looking at the subgroup analysis, really every subgroup of patients responded as well to chemo-Nivo compared to the intention to treat population. There's a few things I've highlighted. This was quite a high-risk population, so there were 2/3, almost 60% of patients in stage 3 disease. The PD-L1 expression did seem to have a bearing, but even the low PD-L1 expressors, so less than 1%, had good responses and better than chemotherapy. So all in all, I think 816 is a very successful study and gave us a lot of confidence that neoadjuvant chemotherapy, immunotherapy can be delivered, and pathological response could possibly be a surrogate marker for disease-free survival. So the next question really is, does pathological complete response have prognostic value in non-small cell lung cancer? And that study gives us some indication that that's the case. The next consideration is, can neoadjuvant checkpoint inhibitor blockade give long-term immunogenicity? And that question is still out there, but we've got some preclinical studies suggesting that. But I thought in order to answer that, I will show you the next study. And these are all the adjuvant studies that we've got. So it's not necessarily answering my consideration, but adjuvant studies we think probably give you that long-term immune response that you want. So these are a whole plethora of adjuvant studies that are underway, and I'm going to concentrate on Empower 010. And this was presented very recently at ASCO, and this was very similar population to the checkmate 816 in that stage 1B, so larger tumors and stage 3 disease were included, except this time this was adjuvant therapy. So patients had their surgery, then went on to a platinum doublet, and then after they completed between 1 to 4 cycles of chemotherapy, they were then randomized to atezolizumab or best supportive care and follow-up. There were, in terms of the primary endpoints, disease-free survival, and then there was a hierarchical analysis, and I'll go through that in a little bit for you. PD-L1 expression was also a stratification point, so we'll look at that. Key secondary endpoints are overall survival. Okay, so this is quite important, so bear with me. So disease-free survival in PD-L1 over 1% in that stage 2 to 3A population. If that was positive, then they would go on to the next stage, which would be all randomized patients in that stage. And then if that was positive, then they would go on to looking at the intention to treat population, including stage 1B. And so those are the 3 groups that were presented at ASCO. Okay, so just the baseline characteristics. There wasn't particularly anything unusual. Squamous represented about 1/3 of patients, whereas the non-squamous were about 2/3. In this study, we had a very small proportion of 1B patients, so about 12% here, and stage 3 disease was about 40%. PD-L1 expression, as you can see, over 1% was performed by SP263 analysis. Right, so here's the disease-free survival curves. The first one shows you the first analysis, which is PD-L1 over 1%, and that is very significantly positive in my view. So hazard ratio of 0.66 and certainly met its statistical evaluation with regards to the p-value. And then the next one we have is all patients in that stage, so including all the PD-L1s. So then you're getting a slightly watering down of that population. And then when you look at the intention to treat arm in that third graph, you're getting even a smaller difference. So my take home really for this is that atezolizumab gives maximal benefit for your PD-L1 expression over 1% in the stage 2 to 3A disease, though 1Bs probably get a small benefit. So looking at PD-L1 expression in the subgroup analysis, and this was a pre-specified analysis, so this isn't something they worked out afterwards. So you can see the patients who benefit most are the high PD-L1 expressors, then we have the over 1%, and I would say the ones who are negative PD-L1, we should not probably be spending the money and the patient's time giving them a whole year of atezolizumab with all the toxicities that it may ensue with very little benefit. Okay. So in terms of safety, there was nothing, no new signals that we could see here. Grade 3 or 4 immune-mediated AEs in the region of about 7%. But of course, you know, you're giving this for a year, so at any point, this could happen, and even after you stop, these adverse events can happen, so we need to be mindful of that. Okay, so that's not really answered my consideration, but that's possibly we've got to wait a little bit longer. Okay, so I'm on to my summary slide, you'll be pleased to hear, and in time, I'm pleased to say. So in summary, we've got, is disease-free survival sufficient to change practice in adjuvant studies? And this is the question that we've asked earlier. ADAURA and PACIFIC, you know, with regards to osimertinib and durvalumab, respectively, have been approved on disease-free survival alone. Disease-free survival is actually, I would argue, very important for clinical benefit to patients, because as they progress psychologically, physically, they deteriorate. So even if we don't give them overall survival difference, if we give them a disease-free survival interval, which is long, then I think that's worth investing in. Overall survival takes years to mature, and approvers and clinicians have to make decisions on the available data that they have. Optimal duration of adjuvant treatment still is arbitrary, and we tend to think a year is about right. And, you know, in breast cancer, we've been trying to de-escalate treatment, and perhaps that's what we might need to think about in lung cancer as well, because we don't want to over-treat patients and spend all this money unnecessarily, and with all the health risks that involves. And just to the last bit at the bottom is for you to all look out for the studies that are coming out with, again, adjuvant and neoadjuvant studies with primary endpoints as disease-free survival. Okay, so thank you.
Well, thank you, Samreen. What a fantastic survey of a, you know, a burgeoning field, really, isn't it? And that was, I think, really informative to have the newly emerging, you know, big randomized adjuvant studies put in context and underlined by the neoadjuvant data that you've discussed there. So once again, I remind the audience that you can submit a text question, and I will ask that for you. While we're waiting for questions to come through, I wanted to start, Samreen, by asking you the same question that I asked Alastair, really, which was around biomarker testing. What are the practical issues for us in our multidisciplinary teams in getting a PD-L1 status in resected specimens? Is it a bit more straightforward because this is just another brown stain for the pathologists to do?
Well, I suppose it depends, because if they've had biopsies pre-surgery, then that's the easiest way. So then, because the pathologists don't necessarily look at what stage it is until the MDT, so they've already done all their reflex testing. The problem arises when you've got a surgical specimen only and they've not had a preoperative biopsy, I guess. Then you have to specifically say that we need to do this, and this testing. So I think the biopsies all get tested reflexly. It's just the specimens that really we worry about. And also, now that there is a change in therapy and the whole field is now changing, certainly in our centre, we do it all up front now. We're not doing NGS, so I'd like to add, so we're a little bit behind with that. Being a big centre, our GLH is certainly not up and running, so we're doing panel testing, and that's really not great. But we are doing it reflexly. Okay,
and maybe I should have asked this question first, and that is, do we actually need PD-L1 status in this context? I think your views on this came across during your presentation, but perhaps you'd just like to answer that point specifically. How guided are we going to be if we had access to atezolizumab today by PD-L1 status?
So I think if approval comes through for checkpoint inhibitors in the early disease setting, which I think is probably forthcoming, if we take the data from the study I've just presented to you, certainly there was very little, if not any, benefit for PD-L1 negative patients. So we will need to test PD-L1 either on resection or the biopsy in order for us oncologists to be able to give the right treatment. So in my mind, yes, we don't
have to agonize too much about whether that subgroup analysis was sufficiently powered and the rest. I suppose there's some other contexts in checkpoint inhibitor use, aren't there? Particularly, well, including in lung cancer, where well, I suppose with that particular drug, actually, where we're quite inclusive about the PD-L1 status of the patients we treat.
I mean, in this study, this was a pre-specified analysis, so it wasn't an ad hoc analysis. So unlike in Pacific, and that's been approved. So I feel that's as good as evidence that we're going to get.
Okay, yes, and I suppose in the adjuvant context, the risk and benefit is particularly stark, isn't it? And offering a toxic therapy for 2 years, which may not move the dial, is potentially problematic. What do we do? I wonder what we do. This is slightly cheeky because it's not really. It's asking you a clinical scenario, which really is not within the envelope of what you were asked to talk to us about today. But does the sort of data that you've been presenting help us deal with the sort of situations, I suppose, that are increasingly coming up in our clinics, where we have patients with advanced disease or locally advanced disease who've had fantastic responses to checkpoint inhibition, and the question of revisiting or visiting for the first time radical treatment, including surgery, comes up, and we do discuss these patients in our multidisciplinary meetings. Does this give us a bit more confidence to say, well, yeah, effectively they've had neoadjuvant checkpoint inhibition, let's give them their radical surgical treatment now?
So I suppose, are you saying for inoperable disease?
Well, I'm saying, for those patients, I mean, I'm not, I suppose they're not common, but they are coming up with monotonous regularity. Patients who might have had a solitary bone or liver disease, which is no longer evident after checkpoint inhibition.
Sorry, I beg your pardon, yes.
On a PET scan, does that give us a bit more confidence to go back to our surgeons or our clinical oncology colleagues and ask for radical treatment, where in the past we may have done that, but on a bit of a wing and a prayer, I suppose?
Yeah, I would suggest you recruit them all into the Saron study. So that's looking at exactly that, but that's synchronous metastases. And what you're asking me is about metachronous onset of metastases. And I think we're all leaning towards that now, depending on the disease-free interval. And that's really important. Your concept of how sensitive the cancer originally was to the systemic treatment you gave them. So all those are the main considerations, and of course the performance status as always.
Okay, questions on the chat. A question which I think is essentially asking about the PD-L1 low but detectable patient group, and do we know from a randomized study you finished by presenting to us what we should do with those patients in between? So the answer to my first question from you was that maybe for patients with negative PD-L1 expression, we spare them adjuvant checkpoint inhibition. for patients with high expression, this looks a pretty attractive approach. What do we know about the 1 to 49 group in this context?
Yeah, so the pre-specified analysis, if you remember, in this IMPALS study was looking at over 1% PD-L1 expression. So that included all of those interim patients, and they all got a benefit. So I think any PD-L1 positive patient, if you look at the data and scrutinize the way it was stratified, in my mind, that was very clear that all PD-L1 over 1% had a benefit. So the benefit only became diluted when you included the negative patients.
Yeah, okay. And then the final question, again from the chat, I think is good for both of you. So tune back in, Alastair, if you're not already. And that question was for a patient in the post-operative setting who's got an EGFR mutation and, let's say, also strong PD-L1 expression, what should we be offering them? Why don't you start, Samreen, and then we'll see if Alastair's got something to add.
Okay, so my take on that is the driver mutation is the important thing. And of course, that will be the EGFR if you feel that that is a definite result. So in my mind, PD-L1 really doesn't hold fire with regards biomarker, a predictive nature of checkpoint inhibition response. So you go for the driver mutation, and which overwhelmingly will be the EGFR, I would say.
Alastair, do you have anything to add to that?
Yeah, no, I deliberately put my patient had a PD-L1 of 55% just to bring that forward. And I agree with Samreen, we know in the stage 4 setting that small, a proportion of EGFR and ALK mutants will have PD-L1 expression, and that means nothing. Certainly in the stage 4 setting, I would strongly advocate that patients with oncogene-driven lung cancers are treated as an oncogene-driven lung cancer and not as pushed into that sort of adjuvant immunotherapy space.
That's great. So we're ending on some consensus, which is always good. Look, thank you very much, Alastair and Samreen, for 2 spectacular talks. Thank you, audience, for some great questions and questions actually which have picked out the really key points rather than labouring on esoteric issues. So that you're obviously listening to our fantastic speakers. That's it for this webinar. We've pretty much kept to time. Tune in next time for the next webinar, which is about a month from now. No, about 2 months from now. We're giving you August off. I think we all need it. Monday, the 27th of September at this 5:30 time slot again. Many thanks, everyone, and good night.